Professor Harkless, you talked about, I think when you give a lecture with Professor Harkless, you have to figure out what he's talking about, but I think a lot of what you talked about was trying to make a difference. And how are you keeping up the persistence, and does that really pay off? Is that what pays off with politicians and policymakers? And I'll ask you first, and then I'm going to ask Kristien van Acker next, if she's here.
The key to, you have to be patient and persistent, and you have to understand the cultural, political, and financial barriers to the problem. And you got to work all three of those simultaneously. Because if you have an orthopedic chief that's standing in the way, he doesn't own the hospital and he doesn't own the medical school if it's state supported. So you have to have the politicians that put political pressure on him to tell him he don't own it, because I pay taxes just like he does, and I'm going there to serve. I'm not going there to take no money from him. I'm going to do stuff that they're not doing in a nicer way. And if you teach everybody in that system will go tell everybody you know what you're doing. And so that's the only thing I know. If you do it passionately and don't get lazy, you'll be productive. I was a farmer. Daddy said plant good seeds every day, and you'll get fruit. You may not get as much as you want, but you'll get some. Thank you.
David?
Yeah.
Wait, David?
Yeah, see,
he's very hot.
Yeah, that's not good. All right. Very nice.
I think we've had some amazing talks, and as we did this, I made some notes to myself here. And I'm going to take them kind of in order. I'd like to start with some comment that Paul Norman made. I visited once in northwestern Canada with an old friend, Al Downs, some vascular surgeon. And he pointed out to me, he said, well, we've got the Canadians and then we've got the Aboriginals. And the Aboriginals have got this terrible problem with diabetes, and the normal Canadians don't. And you mentioned Aboriginals. And would you kind of expand on that and the whole concept of Aboriginal complications having increased incidence and prevalence of diabetes and its complications?
You can speak into the there you are. No, but just you can please project. Just
it's complicated and multifactorial. I'm no expert in Aboriginal health at all, so I may be speaking out of hand here. There's going to be genetic and ethnic differences in terms of risk of disease, susceptibility to risk factors. There will be cultural factors, geographic factors. So it is very complicated and very difficult to deal with, and it seems to be universal. Last year I was in Sri Lanka, and Sri Lanka, like any country in the world, has indigenous populations, so tribal groups who often live in the periphery, and that group in Sri Lanka has terrible health and increased risk of diabetes. So it's worldwide, and I guess every country needs to be aware of it, and maybe there's a unified approach. I don't know.
So let's continue that. As you know, in Arizona, we have probably a very similar issue amongst, not only we live in Pima County, Professor Mills and I, but we have 22 Native American nations in our state as well. And I found to be remarkably similar sorts of issues, not only with disease state, but actually with provision of care and access to care and health equity. Let's move on. Let's move over to the Middle East and actually ask the same question, because Talal, you have an interesting population. You have, I think a couple of 100,000 native Qataris, right? And then you have the rest of Doha, which is growing like no other city in the world, are all expats. Are you seeing the problem in reverse or what? So let us know.
Yeah. Qatar is a growing country in the Middle East, and to grow, we need the help of other people, since we have, just a few of our population. We have to get a lot of workers, and these workers are coming from mostly Asian countries, and a lot of them they come in with their genetic disease, and they come with their tongue language, which we are not able to educate them and train them. Although the government provide a full service for them free of charge and provide all whatever the patient need in regard to medication, both outpatients and in the hospital. The majority of the patients that you've seen, of 12,000 patient visits seen in 1 year, are expats. Now, they're working 8 hours a day. They work in a harsh environment because they have to build the country from the ground up. So they develop a lot of injuries. The housing environment is very suitable, but to reach to our service, it probably take them a very long time. And that leads to the complication of diabetes and the complication of the diabetic foot.
Understood.
I have a question for Kristien and Karel. My first question was, well, quis quoted custodium, who watches the watchers? Who selects the trainers? Where do you get these people from? I mean, is it better to do it the way you're doing it, the old step-by-step, which is you go there, or do you have any idea of these surrogates for Karel and Kristien are going to do as good a job as you did?
I'm happy with your question because I think the success will depend on that too. So what we did, for example, for the South American region, right? So I think we had at least to start with our champions like Linda Pedrosa, who have already showed her success, as Andrew told us. Then with her, with some real champions of the Spanish group, we said, okay, it's not to us to decide in our society who will be the champions of your region. So we asked them to negotiate in their own region, try to find out who are the real champions and those who are in the capacity to implement a national program. Because you can be a wonderful doctor or a nurse, but you need also capacity of organization and negotiate with other persons. So then they selected, and we had 2 important criteria, I think, that is also necessary for a success. First of all, we asked them to show us, those who are the participants, please show us that you are in contact with your Minister of Health. So they had to show us a letter or a mail or whatever, that we are sure there was at least a contact. We can't ask at that time that there is absolutely a cooperation, because that will...
And Larry has one from the Lieutenant Governor, so...
Yeah, absolutely, yeah. So, good candidate. Second thing is, if you really want implementation, the patients are central. So I think the involvement of a patient organization is so important. So we asked them, the participants, and always in pairs, please show us that you are recognized by your patient organization. So these were the items we developed for these Train the Foot Trainer courses, and more we believe for implementation success, it was important.
By the way, we have microphones here from anybody in the audience who wants to ask a question. Please step up to the microphones and be recognized. Karel.
I changed a little bit the subject. I like to stress, but I didn't know that in our talk, that unfortunately, although we get support from the Minister of Health, we never received any penny from all our projects we did from the Minister of Health. And I hope that will change. It has to change, because we save a lot of money. And not only the money, but also, in suffering. And I like to say that the money comes from the World Diabetes Foundation, the IDF, that's the International Diabetes Federation, but as I said, also from the Rotary Club of Ledbury. They collected 36 Rotary clubs in the world to donate money. And by the system of a matching grant, they raised altogether $400,000 to make these programs in the Caribbean possible. I think that has to be mentioned. So don't be discouraged if you don't get money from the Minister of Health. There are other ways, although we have to strive for it and we have to keep pushing.
Can I move this over? I was going to ask you, Kristien, this, but since you've already answered, I want to ask Ajit this. How do you keep up the, when you leave a village, when you leave a city, you've given a talk, you've put on a workshop, you think you've made a difference. Have you really made a difference? And when you leave, how do you keep up the excitement amongst those clinicians that you've just trained, the technicians, the nurses, the physicians and surgeons? Or can you? And you know, how do you make an evangelist?
Yes, in general, there is a lack of awareness regarding diabetic foot problems, not only in the patients, as even in the physicians. We do hold regular CMEs, conferences, and update them. And we have an ongoing sort of a teaching program with the primary care physicians on the seriousness of diabetic foot problems, so that patients who come to them who cannot be managed at their level, they can be transferred immediately to a center where proper treatment can be given, and of course, limb and life-threatening problems can be avoided.
So it's sort of like I mean, and this is something that I think Professor Bakker talked about many years ago. It's like levels of a trauma center. You might have a level 1, 2, and 3 unit based on certain criteria, and I think that's definitely the way forward.
But before we go to that, I just want to let the members of the panel know that we encourage members of the panel to ask one another questions. We always like to encourage little spats and disagreements. So if you don't agree with what the other guy says, let him have it.
Oh, here comes.
Tony's leaning forward.
Tony was sort of gesticulating and leaning in.
Well, David and George, this is the first time in 30 years I sit on a panel flanked by 2 moderators. You're scaring us. I think this is why we're not asking a lot of questions.
We're coming at you kind of like 2 Beats
coming at us from both directions. I mean,
yeah, there you go.
All what we need is just sitting there, and we're all set.
Well, Mills is over there checking kind of the scores in March Madness right now in basketball. For those of you watching from far away, all hell has gone loose in Arizona and all around the world because, of course, we're having college basketball. I know it sounds obscure, but bear with us.
Dr. Najifi, please.
Thank you so much.
You've been so patient, Professor Najafi. Straight out of Tehran.
I don't know if you can hear me. Okay. Excellent talks from everybody, very educative. I was very impressed by a step-by-step program and also the program that they have to increase the worldwide education and prevention of diabetic foot ulcer. But there is another issue that I'm not seeing much that address, in particular when we are addressing the prevention of diabetic foot ulcer, and it's a problem of aging that is not a world epidemic. Our population is aging, and this is not a problem just in the United States, it's really worldwide. And if we combine aging and diabetes, there are some other problems that can complicate the prevention of diabetic foot ulcer. One of these problems is fear of falling. We just did a study and we demonstrated that over 70% of older adults with diabetic peripheral neuropathy, they have fear of falling. The problem with fear of falling is that sometimes they don't care about the foot, they try to protect their hip because they know that if they fall down and break the hip, they lose their independency. So they limit their activity. Because of limitation of the activity, there is not enough blood flow, and the risk of diabetic foot ulcer is increasing. The question that I have for the panel is that, what are the other strategies do we have for also addressing the problem of aging, whether it's a classification of the foot at risk, whether the intervention about the type of the footwear that we provide to these patients to enhance and they cover the fear of falling, or what are the other strategies that we can do for aging population?
Sidawy, then Boulton.
Yeah. Are you asking from point of view diabetes?
Yes, exactly. How we can overcome the fear of falling, because we ask this patient to be active, to do exercise, but they don't do exercise because they have very high fear of falling.
Because, you see, vascular disease, whether you're diabetic or not, it happens with aging. So you've got here two factors that are going on. You have diabetes and you have vascular disease, and both of them actually converge to cause all the problems we're talking about. I think the one area that we underestimate and we don't talk about is that whether if we prevent the transformation or the conversion of pre-diabetics to diabetics, whether actually we will stop the progression of vascular disease and neuropathy. Actually, if you take a group of patients, which we've done a few years back, who come with normal fasting glucose and come with a foot lesion to your clinic, and they have tibial disease, which is the pathognomonic distribution of vascular disease in diabetics. And you do on these people with normal fasting glucose, you do on them oral glucose tolerance test. 44.5% of them turn out to be pre-diabetic. So what's happening is, even before glucose level in the blood increases, the effect on the blood vessels and probably on the nerves as well is happening. So when you ask the question, can we have these people who are older and they're afraid of walking, exercising because they're afraid of walking, what you can do for them? I think at that stage, with all honesty, I'm not sure you can really reverse the actual problem that caused the complication that we're dealing with. And I think the care of the foot at the time will play much more role than preventing quote-unquote diabetes because of sedentary life.
So before we get to the obvious speaker on this as well, Tony, Kelly West observed that with tibial calcification in his book. When did he write that book? In the 70s? So your observation has been well established, not with glucose tolerances, but he did it on tibial artery calcification and found the same sort of thing. Andrew, you have some thoughts, I'm sure, on based on your research, don't you, on the risk of falling and so forth?
I mean, diabetes itself is said to be premature aging, and there's no doubt that the aging population is increasing in all developed countries and will in developing countries. Sure. With respect to IGT, I have to say that I've never used a glucose tolerance test to diagnose diabetes yet, and I've been doing diabetes a lot of years. It's rarely needed. Of course, if you want to find pre-diabetes, you can do glucose tolerance tests, but research from our group and others have shown that people with IGT undoubtedly do have some neuropathy, but it tends to be small fiber. So it's the painful variety, and large fibers are preserved generally in IGT. The fear of falling is very true, and our research has shown that patients do not complain of this because they can't believe it's related to diabetes, whereas, of course, it's due to loss of proprioception, large fiber neuropathy. And this is associated with quite marked depression in many patients. And there is a very real risk of falls, and as you are doing and we're doing, we're looking at gait and gait on stairs, as I mentioned, and I think we need to look at strategies and exercise training and reassuring patients, and also perhaps physiotherapy. To date, trials have been disappointing, but I think we've probably been looking too late. So I think there are things we can do, but a lot more research is warranted in this area because these falls lead to not only foot ulcers, fractures, but also Charcot changes as well.
But do you think you can prevent the progression by
research,
doing so? I mean, that's, I think, the question. Should we be spending money on it, on the prevention?
That, it was always said you can't reverse neuropathy, but our studies using corneal confocal microscopy, which is a non-invasive way of envisaging peripheral nerve in the cornea, we've shown that even in patients having SPK, simultaneous pancreas kidney transplants, there is chance of regeneration. We're seeing regeneration of nerves, small fibers, within 6 months of normalization of blood glucose. So I think that this is an area that's been a bit pessimistic, because we've used the wrong test of large fibers. There may be room for recovery, even in advanced neuropathy.
Andrew, I have a question for you. So am I, just so I can unify this, so am I to think that obesity and aging are comorbidities of diabetes, or is diabetes a comorbidity of aging and obesity?
It's probably very much intermixed, all three of them.
I don't think we know. And I want to make a comment that I attended a ASP, the Associated Specialty Professors in Internal Medicine. I participated in a workshop, which was a precursor to the NIH meeting, but they had the head of the NIA, the National Institutes of Aging, and the Heart-Lung Blood Institute, and that was a Professor LaConta. He gave a lecture on aging, and he said it starts with the DNA, and he probably had about 50 things down to the organelle at the cell level and everything as related to this thing called aging. But what's happening in NIH now is that everything that's going on in NIH will have aging as part of it because we haven't studied anybody in aging. That was one of the concepts that came out at a meeting, and these were all the geriatric professors of internal medicine around the country. It was a great meeting, and I learned a lot about aging and the process. So stay tuned, Bijan, for that. If you're going to apply for a grant, if you do that, you'll get funded.
Thank you. I would like to add just a point about the intervention.
Hold on, you're not,
what
are,
you
you,
can
are,
do.
you, are you allowed to add a point?
Sorry.
It's such a long, please, go ahead.
So, you're right, though unfortunately there is not much research in this area that what we can do, but as Dr. Talal in his talk he mentioned is that we demonstrate that if we provide a personalized exercise to lower extremity, we can help this patient to be more active. Of course, in ongoing preliminary results demonstrate that also we may enhance the vascularity in lower extremity by increasing the level of the activity. Of course, it's really at the beginning of the research, but again, some other colleagues demonstrate that providing appropriate footwear also can help and overcome the fear of falling. But there is not much actually knowing in this field because the leaders like you actually need also to guide us. What are the areas that need to be addressed and also educate patients to address some of the problems when we combine aging and diabetes?
If I may, in our clinic, when we are doing this research and regarding the personalized exercise for the patient using this virtual reality, most of these patients who have diabetes and have loss of balance, and especially when we examine them, closing their eyes or open their eyes, they still have a sway. And after using this exercise of obstacles crossing, the balance has increased by 76%. And those are older people that we're doing this research on them. And when we examine them as they're walking, pre-test or pre-exercise, they were walking very slow and very unsure of themselves. After the exercise of only 3 or 4 weeks of twice weekly, and this has improved their balance tremendously. So I think the bill or the politicians in the United States, they got it correctly. Get them back to exercise. Maybe they'll be gaining everything back, and they don't need anything. They won't be falling.
I think this is really an interesting signal, and to your point, to your skeptical point, which I think is valid, there may be something to this, and we'll see about getting out and getting to folks even after they've had what we've considered to be really end-stage problems. But I guess to be continued, maybe to move it, did you want to comment?
Yeah, just one brief comment. But I think it behooves us, when we do that in patients with neuropathy, is that we give them the appropriate footwear. Because you don't believe the number of patients that I've seen that we advise them to go and exercise, missed their podiatry clinic, didn't have the appropriate footwear, came back with an ulcer just because they started walking with the wrong shoes. So there's a lot of factor here, folks, that we need to pay attention to.
I would argue that we in the developed world, and particularly here, or I'll just say me specifically, I don't think I do as good a job as Dr. Varma does in southwest India. And with footwear. We talk a good game and we do our best, but we still have trouble getting these most simple things paid for, and that took an act of Congress, literally, in the United States in 1990. And I think we're still woefully inadequate there. But let's move from that just to, and we'll get to, I know you had a question of Dr. Skrepnek in a minute, but let me get to Dr. Berlanga, and then secondly to Dr. Romanelli right after that, because they're both related. Jorge, over the last 20 years, you've been struggling with this protein, and it's been a fascinating journey watching it and watching these data develop. And maybe what you have stumbled on might be promising for the future of wound healing, in that when you're delivering EGF, in this case, a growth factor to the wound, you are avoiding or you are injecting around and under the sort of hostile inner city of the wound, which is full of these nasty proteases and this big and debris and whatnot that destroy a poor little naive protein before it has a chance to make a difference. So is going out into the, forgive my translation, I can't remember the translation for the suburbs, but outside the inner city, histologically, better than going than injecting just into the wound? Because we've seen failures with growth factors, and maybe that's part of the reason.
And just to add to that, so you can finish it off, and then how does that correlate to not only administering this compound, but also the role of debridement? If you might add something on that.
One of the first stumbles we had was the first approach of applying growth factors on the surface of the wound.
Is that right?
Yeah, yeah. Actually, it still survives some cream in which there is the hope that the growth factor will diffuse to the areas where the cells with the biological capability to respond are lying on. But the point is that there is a lot of work done. The pioneer of this was our professor and friend, Cal Cohen, who in the early 90s demonstrated the hostile environment of the chronic wounds. Afterwards, there was a research by Professor Greg Schultz and colleague from Australia in which acute surgical wounds were able to degrade ex vivo growth factors. We made a lot of experiments during the 90s, and we had actually, if you have a growth factor or a chemokine which may potentially enhance the healing process, you have two choices. Or you engineer the formulation so that the growth factor could be protected against degradation and so on, or you try to deliver the message where the cells are available and the receptors are available. And the other point is that it seems to be a sort of a cellular gradient along the axis of the wound. So the more superficial cells are more reluctant to proliferate.
You see, that makes sense.
The deeper you come, the cells are more capable.
This is just like Dante's Inferno. It is exactly like that. Dante, like literally, 700 years ago, he figured this out, didn't he, Professor Romanelli? By the way, that was an awesome slide, FYI. That was just great. That's like a funnel into hell, going down deeper into the wound. And it's the same thing that he's talking about, isn't it? We're injecting these things.
Yeah, I agree with you, David.
So? Are you confused? I'm sorry.
No, I should say that wound pathology is in a very early stage. In the diabetic foot field, you mainly take a biopsy for culturing. Probably in the future, you will take a biopsy also for histopathology. There are plenty of interesting markers, biomarkers, which in the future will drive the treatment. We've seen in general dermatology already that type of targeting for new drugs and of course with the offloading, revascularization, but it's something histopathology will help.
Yeah, but again, I think this is an entire area, and you're doing more work for it with negative pressure and the sensors there, but getting back to more receptive receptors.
Yes, if I can add on the HeparoProt, from a clinician point of view, using this product, we try to inject it away from the hostile environment, to try to grow it, if you may, from the ground up, and allow the tissue, the good tissue, to push away the bad tissue out. And it does work in that aspect.
Well, what we've done forever is to hit the reset button on the wounds by surgically correcting them, by debriding them. But maybe there's some truth to all of this.
And then regarding remodeling your question, the tissue actually comes out to almost like the same tissue, even if it's a plantar tissue, rather than if you say from a graft from a dorsal skin, and it comes out to be a real, just like the genuine tissue of the
To be continued. Sir, you've been so patient.
Yes, thank you. I've very much enjoyed the presentations to date. It's been inspiring, actually. I had a question, though. There's the saying about having an ambulance down the valley or a fence at the top of the hill, and I think Obama, while I didn't vote for the guy, the ACA actually does sort of, I like the principle, which is to prevent. But I just wondered, in terms of, we've talked about aging and other causes of diabetes, but, and we're talking also about Aboriginal populations, what role has diet and the change of the diet played in these populations, for example, that have been incorporated into our society to some degree in the development of diabetes? In other words, we know that obesity and diabetes go hand in hand. How does the food supply impact, do you think? I'm just interested in your opinion. How does that impact these populations?
Great question.
This has been popularized many years ago by Paul Zimmet from Melbourne, who talked about Coca-Colonization of the world, or acculturalization. And the classic example was the Polynesian island of Nauru, which had were hunters-gatherers until they realized they were sitting on a sea of bird shit, which was potash. And they started to mine that, and they waited for the fast food, the Big Macs and the Burger King to arrive, and their prevalence of diabetes went from less than 1% to the highest in the world about 15 years ago, where it was over 35%. So there's no doubt that this is diet has a major impact, and westernization, as Paul Zimmet popularized, and he's absolutely right. And if you look at migration of populations, there's a genetic risk plus environmental, and the environmental is the poor diet that we certainly have in most Western countries, and we're all guilty of leading that way. Most of us sitting up here, not personally, but our countries. Not all. Cuba's a very interesting example, because at the end of the Soviet Union, there was a time of very great difficulty because they had lost their support, and the actual prevalence of diabetes went down. It's a third of the rest of the Caribbean islands. So that's an excellent example where people walk more. The cars are beautiful. I got in a 1950s cab. It was wonderful, an old Cadillac. But people walk more. The diet is better, although I think the prosperity is returning. And sadly, we may see the reversal of this decrease that we saw after the end of the Soviet Union.
I love the principle of the step-by-step program, but do they also teach in that program, when the diabetes educators, they also teach diet at the same time? I'm just curious. We talk about getting nutritionists involved, but do we really teach diet when we do the step-by-step, which is a wonderful program?
One of the items is, and I like the title that's used in the program, is treat the whole patient and not the hole in the patient. Meaning that we have to consider, if we are going for national programs and for stimulating people to install food clinics and having these programs done on the first line, that of course it's not only the ulcer or the prevention, it's the whole patient. So also what is tackled is the depression state of the patient. Nutrition is a part of it. But in some days you can go in detail. So what we deliver is just the ideas and the resources of literature. But of course, it's taken into account. Absolutely.
Thank you.
And Professor Bakker has a question, a final question to the third most bald person on this panel.
Thank you, David. I'd like to ask my panel colleague, Dr. Grant Skrepnek. First of all, thank you for your impressive lecture. It's a very important but unfortunate statement. The big question is there going to be a change after these reports? I always say that podiatry is the cornerstone of food care. Now, you have clearly stated that is basically true. Do you think there are changes in the United States or in Arizona or?
Actually, I think, also to incorporate a number of the comments and discussion from the panel and from the audience. We don't know. I've done a great deal of research in the area of adherence. And this is not only adherence to physician advice from the patient perspective, but also adherence from the provider's perspective. Do providers adhere to known guidelines? Do patients who are taking oral chemotherapy, why do they discontinue their medication? There are over 250 identified variables that are associated with someone's decision to engage in some activity, either preventing or enhancing their health care. And, you know, I'm also involved in a great deal of disparities research through the National Cancer Institute and other organizations. And one of the key things that I see healthcare providers, myself being included, I'm a pharmacist, is that we often think that we're going to educate patients, and that when the patient is this incredibly smart person in terms of health literacy, that's going to drive their behavior. And, you know, I venture to say something quite bold, but nothing is more incorrect than that. It is a start but not an end. One of the comments that came up earlier was actually from Peter Drucker, the father of management. If you can't measure it, you can't manage it. Individuals, you as an employee, you as a patient, we all have our own unique things that we bring to the table that are very important to consider in the personalized care of us. And there are models that exist to better understand that. The issue is that they're not being applied. You know, in Tucson, when I was working, we never really understood why a number of indigent individuals would not come in to the community diabetes centers. Well, we found out after asking something quite simple. It took some individuals 6 hours on public transportation to get to the clinics. So the issue is I think first we need to better understand patients as individuals. Is there a fear of falling? Well, let's address those fears. Is there an injection fear? Why do individuals stop taking insulin? Well, around the border, individuals will see that whenever anyone begins taking insulin, they see them die, so they don't want to take insulin. So you have to address very specific things to your patient populations. But beyond that, why is it that our county hospitals are in the United States, why are they essentially equivalent to third world nations in the level of care? Well, part of that involves infrastructure, and that's actually getting back to this question. What do we think is going to happen? I think that first we need to understand patients as individuals, then we have to begin addressing issues relating to infrastructure. And that's a very, I think, a key concept to begin to assess and to address, because the future is yet to be told. And I think those are the two areas that we need to begin to focus on that are going to have the biggest bang for the buck.
I think we started, ladies and gentlemen, with an angry podiatrist there on the left. We ended, by osmosis it appears, with an angry pharmacoeconomist. But I think all of us need to bottle some of that enthusiasm and that anger and transfer it to our patients, and maybe make some angry patients, because they are the ones that may drive the politicians to act. And I think it's a top-down and a bottom-up approach. And boy, have we ever heard it this morning. I mean, this was spectacular. Ladies and gentlemen, and I just want to thank all of these just glitterati intelligentsia.